Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, premier education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to be able to present Dr. Justin Gainor, who is the Director for the Center of Thoracic Programs at Mass General Hospital at Harvard Medical School, to talk to us a little bit about new targeted treatments in non-small cell lung cancer, focusing on RET and HER2. And with me in the studio today, we have Dr. Riaz Shah, who's live with us, who's an oncologist and will be taking on the questions and discussions from the audience today. So without further ado, I'm going to share my screen and start the video.
Hello, my name is Dr. Justin Gainor from the Massachusetts General Hospital. I'd like to thank Dr. Lim and colleagues for the invitation to speak to you today. I'll be discussing targeted therapies in non-small cell lung cancer with a focus on RET and HER2 alterations. Here are my disclosures. Over the last 2 decades, we've seen an explosion in regulatory approvals of targeted therapies in non-small cell lung cancer. The pie chart in the center shows the distribution of oncogenic drivers in the disease, and we can really see that we now have 11 distinct drivers for which we have approved targeted therapies, ranging from small molecules, which is the majority of approved agents, but we now also have some bispecifics, and as you'll hear about, some antibody and an antibody drug conjugate. I think it's helpful to take first a step back and a broad view of what are some of the key advances in precision medicine in lung cancer over the last several years. And if we think about the commonalities for many of these agents, what we're seeing is that first, an effort to optimize next generation inhibitors for known targets. We're seeing on that list also the ability to start drugging previously undruggable targets. We're seeing development of combinations, and then lastly, we're starting to see these agents move earlier into stage 2 and 3 disease. I'm not going to talk about the last two, but I think it's helpful to review that nonetheless. When we start thinking about TKIs in particular, I think there are a couple trends that we should highlight. And these are, one, an increased effort to develop more potent agents. Two, selecting agents that have improved selectivity against the target of interest. 3, increased CNS penetration. And then 4, taking the biology into account, that is, selecting agents with activity against known or predicted resistance mutations. And I think RET fusions are a great example of how those lessons have really accelerated drug development in this space. So RET fusions are found in 1 to 2% of non-small cell lung cancer. We also know that RET fusions are also found in several other tumor types, albeit rarely, most notably papillary thyroid cancer. On the right just shows you that the normal RET signaling and how this is dysregulated in the setting of RET fusions. It's also important to highlight that in addition to fusions, we know that RET can also be altered via point mutation, as is seen in medullary thyroid cancer. So when RET fusions were first discovered in non-small cell lung cancer circa 2012, we had already learned a lot and had the experience with ALK and ROS1, right? Fusions that were associated with certain clinical pathologic characteristics, and we had already seen beautiful responses to targeted therapies. And so there was an effort to try to start repurposing so-called multi-kinase inhibitors that had anti-RET activity. I'm showing on the left just 2 examples, cabozantinib and vendatinib. But what we quickly learned is that the activity of these agents was rather modest. We were seeing response rates in the 20% range. And the thinking being that these are really promiscuous targeted therapies hitting many kinases, including VEGF. And this led to a concerted effort to develop more selective RET inhibitors, most notably selpercatinib and pralsetinib. And you can see here that these agents were much more selective and also much more potent, and had also been engineered to overcome some of the predicted known resistance mutations, such as the gatekeeper mutation. And so, when these agents entered clinic, so we'll start with selpercatinib. Here's data from the Libretto 001 study. This was the phase 1 study. And you can see very beautiful waterfall plots in the treatment-naive setting, response rates of 85 to 90%. And in the population of patients previously treated with platinum, we see response rates 64 to 70%. This data has since been updated. You can see here median progression-free survival in the 16 to 19 month range in patients previously treated with platinum had not been reached in the treatment-naive setting. Just a word on common adverse events. The most common, dry mouth. You can see diarrhea. Despite us saying that these are selective inhibitors, they do still hit VEGF to some degree, and so we certainly can see things like hypertension in both selpercatinib and pralsetinib, LFT abnormalities, and fatigue. What about the other agent? This is pralsetinib. This is the ARROW study. We can see in treatment-naive setting, response rate 70%. Patients previously treated with platinum doublet, 61%, so a very active agent. And then when we look at the updated analysis, we can see that in patients previously treated with platinum, we see median PFS 16 to 17 months. In patients treatment naive, a little bit lower, albeit you could see some asterisks there. Part of that is driven that the initial phase 1 study excluded anyone who is deemed eligible for platinum doublet chemotherapy, and so this is a different population. The most common adverse events for pralsetinib include neutropenia, likely driven by some JAK inhibition. We also see some LFT elevations as well as hypertension, just like with selpercatinib. And then more recently, we've seen a randomized study. So this is the randomized study of selpercatinib versus platinum doublet chemotherapy, either with or without PD-1 pathway blockade. And you can see a clearly positive study. Some would argue, I have argued that was this really a necessary study? We recognize that that the science certainly supports that the targeted therapies did so much better than historical chemotherapies, but recognizing in order to ensure global access, including payment, that's what drove this clinical trial, and it's a clearly positive study supporting targeted therapy as first line. Just a brief word on targeted selective RET inhibitors and CNS activity. You can see here that in both, these are both the phase 1 studies. On the left, selpercatinib, on the right, pralsetinib. These agents are clearly very active in patients with measurable CNS disease. One of the questions, though, moving forward is what about next generation RET inhibitors? Is there a role to improve upon this? And it's been complicated. It's been complicated because one, and I'm showing you here, the 5 agents that have been in development. 2 are crossed off because they are no longer in development. It's been complicated because one, this is a rare subset of patients, right? 2, the approved agents right now, selpercatinib and pralsetinib, actually perform quite well. And so most of these agents are going into the resistant setting. And that's been challenging. It's been challenging because a majority of patients treated with the selective RET inhibitors don't develop on-target RET resistance. That is, resistance via this gatekeeper residue, the V804, or the solvent from mutation. It's only about 10% of patients. And so then you're talking about 10% of a 1% population. And so it's really hard to develop drugs in that setting. I wanted to pivot at this point to talk about HER2 alterations, because I think this is, there are some similarities and some differences. So one, this is a rare alteration. So if we talk about HER2 mutations, 1 to 2% of non-small cell lung cancer. You see here on the left kind of the distribution of the alterations. Most of these are in the tyrosine kinase domain, although some are in the extracellular domain. And then, as we'll get into, the newest biomarker is HER2 protein expression at 3+. We should now be testing for that. So I'll lead with HER2 mutations because that's where we have the most data, and this is where we have approved agents, with the most data and the most track record. So HER2 mutations, we've learned over the years it's been quite difficult to develop tyrosine kinase inhibitors against HER2 mutations, largely because of side effects. So we see a lot of EGFR effects of these agents. Most of these were both HER2 EGFR agents. So lots of skin rash, lots of diarrhea. And so where the field has moved is antibody drug conjugates, specifically trastuzumab deruxtecan. We can see on the right, this is data from the Destiny Lung study where you can see the waterfall plot, a very nice response rate with the antibody drug conjugate and a progression-free survival median here of 8.2 months. Now, in the development of trastuzumab deruxtecan for lung cancer, different doses have been explored. Both a 5.4 mg per kg dose used more commonly in other tumor types versus the 6.4 mg per kg dose. You can see here that the response rates look pretty comparable, right? 49 versus 56% respectively. Numerically, maybe a little bit lower median PFS with the lower dose. But really what's driving use of the lower dose, and this is what the approved dose is of 5.4, is the toxicity. So lower rates of pneumonitis, which I'll get to in the next few slides. But just for completeness, in the US, we recently had an approval of trastuzumab deruxtecan for patients not with HER2 mutations, but for patients with protein overexpression 3+ via immunohistochemistry. The data here supporting this is on the left. You can see in the waterfall plot in blue is the 2+ IHC, and in the green is the 3+. In patients with 3+, the response rate was 53% with a median duration of response of 7 months. And so that's really what led to the approval. Now, this does alter, testing strategies, meaning that, in our clinics now, not only am I sending NGS and not only am I sending PD-L1 expression, I'm now starting to add other IHC, including HER2 IHC. A few words on toxicity of trastuzumab deruxtecan. Frankly, this is a harder drug than being able to use a TKI, right? Compared to the selective RET inhibitors, right? This is still chemotherapy. I would say chemotherapy version 2.0. We still see nausea, we still see fatigue, decreased appetite, etc. The adverse event that is of particular interest is ILD or pneumonitis. I showed different manifestations of it on the left side here. So some it can be quite fulminant, others a bit more subtle. But it was really the pneumonitis risk that led to the use of the 5.4 milligram dosing. You can see in the tables on the right, these are adjudicated pneumonitis rates. You can see that rates at the higher dose of 6.4 mg per kg, were around 28%, whereas if you use a lower dose, 7 to 15%, depending on whether patients had received prior checkpoint inhibitor. So clinicians really need to be vigilant about ILD in patients with non-small cell lung cancer. And then just for the sake of completeness, it's not that we've forgotten about TKIs. There's still active development of TKIs in this space. On the left, this is taken from a recent publication in JCO by John Haymack, the zongertinib. This is a small molecule kinase inhibitor response rate here, about 30% in patients with HER2 mutations in lung cancer. On the right, this is an agent, BAY292, higher response rate, but about high rates of toxicity, including diarrhea. So more to come with these agents. And so I'm about at time, so I just wanted to summarize this, that targeted therapies have transformed management of lung cancer. We now have 11 distinct targeted agents with approved therapies. I reviewed the standard of care for RET fusion positive lung cancer is really use of a selective RET inhibitor, selpercatinib, or pralsetinib in the first line setting. We have more work to do in the later line setting. For HER2, trastuzumab deruxtecan is now an approved agent. It's approved actually in the second line setting for previously treated HER2 mutant lung cancer and HER2 overexpressing at 3+ solid tumors. The dose optimization studies were important, really established the lower dose of 5.4 given the risk of drug-induced ILD, and clinicians should really be aware and vigilant for that adverse event. And so with that, I'd really like to thank you for your attention. It's really been a pleasure. Thanks.
That's great. Well, thank you very much to Dr. Justin Gainor on a fascinating talk today. Riaz, can I maybe start with you to ask you how successful have these agents been in advanced disease, and when do you foresee them coming into the early stage resectable setting?
Yeah, well, I mean, these are obviously one of the key issues in any of this is what is reimbursed in your nation, and reimbursement rules do vary quite substantially across the world for many of these more novel agents. So we have, in terms of RET fusions, as Dr. Gaynor outlined, we've got, pralsetinib and selpercatinib. The key thing here is, for example, here where I am sitting in the UK, pralsetinib is not reimbursed, but selpercatinib is. So the first thing to establish is, do we have a reimbursed treatment option in my country? And then the next real critical thing is, can I be absolutely confident that I'm picking these patients up? Do I have a baseline upfront molecular testing paradigm that will really detect these patients? Because, as outlined, they're not that common. And so you don't want to miss them. And what I think is one of the key take-home messages in any of the common, any of the lung actionable mutations where we have active drugs, is that we have a drop-off. So if you start people on first-line therapy, then some of them will progress on first-line therapy, and they will never be fit enough to receive second-line therapy. So you want to be giving your targeted drugs in the context of RET fusion, certainly, you want to be giving them first line, not second line, right? Because they're highly active. So you need a really good upfront testing paradigm to pick these patients up and initiate first line targeted therapy and not go down a path of giving chemotherapy. Now, the question about what to do in early stage disease is really an open one because the space in early stage lung cancer is becoming exceedingly crowded and complex with post-operative strategies, pre-operative strategies, and perioperative strategies, and largely revolving around chemo IO. We only have two actionable mutation-driven randomized data sets for EGFR and ALK. So this is all stuff that needs to be worked out. Should a RET fusion stage 2A to 3B be treated differently to a non-RET fusion? So you need to do prospective studies to validate whether that is the case or not.
Yeah, definitely. That's an interesting point. And I think that these studies are already underway, and I understand that some are already completed with a view to getting a readout at some point. I know selpercatinib on Libretto 432 has completed, and maybe that's one of the first non-EGFR or ALK, alteration that we're going to follow suit. But you're right in that this field's becoming more and more crowded and more complex. But for me, I've always seen it as if you have a molecular targeted alteration, then you go down a different pathway. And hence why at the moment, with the neoadjuvant treatment, it's mandatory for us to test for both EGFR and ALK. With the new agents coming up, I think that this is going to change the paradigm. I think one interesting outlook as well is that the targeted treatments at the moment after resectable disease, they are so far oral medications, which tends to be quite easy to administer. The two which are, I think, on the horizon, which is both RET fusions as well as HER2. For the RET fusions, can you maybe explain to the surgeons how are the medications administered? Is it oral or intravenous? And how about the HER2 as well?
Yeah, well, pralsetinib and selpercatinib are oral medications, so they're very straightforward. Um, you can look up the dosing in the SPC document. So it's not a big deal, but they're not licensed in any adjuvant setting at the moment. In the HER2 context, so trastuzumab deruxtecan is an antibody drug conjugate, so that's an intravenous treatment. Remember, antibodies are very big molecular structures, very high kilodalton size. They're not already bioavailable. But the new TKIs, which seem to have quite high um, response rates, 70%, which you saw, versus TDXD, which is probably nearer the 50% mark. Those are tyrosine kinase inhibitors, a bit like the EGFR and ALK inhibitors. These are orally bioavailable drugs. The main difference between zongertinib and the Bayer one being that zongertinib is covalent and relatively wild-type EGFR sparing, because HER2 is is EGFR2, and EGFR1, same family, is what we treat as EGFR mutation positive lung cancer. So the toxicity profiles of these drugs do overlap. So when you look at TKIs that are HER2 targeted, some of them spare wild type EGFR and some don't. So songertinib is a wild type sparing TKI. The Bayer compound doesn't appear to be, so it seems to have much more in terms of on-target EGFR toxicities like diarrhea and skin rash, which you'll see in the published data sets that are coming out.
On that
So
note,
yeah,
yeah, some
yeah.
surgeons follow up their patients up to 5 years. And as we get more and more adjuvant targeted treatments, perioperative chemo IO, do you think it's going to be appropriate for surgeons to be in charge of post-operative follow-up when they are likely to have to screen for these adverse effects from targeted treatments?
I think that's a really interesting area. So my own personal view on this, which is evolving, I don't have a final opinion on this because over time it is evolving, is I do think we need to look at this because when the patient relapses, they need to go on to targeted therapy usually. Usually a relapse is not a curable relapse and may need targeted therapy. And if they're under the surgical umbrella with oncologists in another hospital, perhaps 20 miles away, it takes time for the referral to get through for the patient to access appropriate oncological treatment. So I think this is an important discussion for us to have. Someone has to do it. These patients need to be followed up, and we need. I think I really worry about patients that have TKI actionable mutations that are have a preponderance to go to the brain, because one of the areas in this once patients enter surveillance is that perhaps surveillance of the brain isn't done anywhere near as in anywhere near as detailed a way as perhaps I might want it to be done. So when I look after EGFR and ALK patients and they finish their targeted therapy, I tend not to discharge them back to anyone. I keep them in my clinic because I am doing over and above normal surveillance because of my concerns about isolated brain relapse. So I think someone has to do it. It doesn't really matter who the professional is, I don't think, as long as there are very clear guidelines that can be followed. And this sort of thing lends itself to, allied healthcare professionals. You can protocolize this and make it straightforward. But what we have to make sure is we pick relapses up early because they can be rescued. There are cases of patients who've had isolated CNS met, a small met 2 years after surgery. They've had SRS, they've had no extracranial progression, and they've remained disease free. So I think this idea that we might be able to pick up distant disease very early and intervene is a real one.
Yeah, thanks. Because at the moment, I don't know if oncologists are following patients up apart from those which are actively being treated with adjuvant or long-term adjuvant treatments. At the moment, the perioperative IO regimens can go all the way up to 1 year, right? So there will be a gap of patients who are not receiving adjuvant treatment, and probably that's going to be an important subset as to who follows up this group of patients going forward.
I think that's right. And the other thing, Eric, that concerns me is we're talking about stage 2A to 3B, resectable disease. But there's people with earlier stage disease who don't go anywhere in the oncology umbrella, stage 1 lung cancers. And what is the relapse rate of an ALK patient with a resected stage 1? Do they need a nuanced surveillance program that's tailored to that particular mutational subtype? They don't see oncology at all.
No, you're right. And I think that the answer to that is going to be further clinical trials. And as we know, ADAURA 2 is now looking at stage 1 for osimertinib with the potential to improve outcomes. And I'm sure going forward, companies making, ALK inhibitors will be looking at the stage 1 population as well, because it's the targetable alterations that has the biggest impact in terms of hazard ratio. So closely around 0.2 for disease and event-free survival at the moment. And I think that's what's going to make a comeback for stage 1 disease. But as you're proposing, I think it's quite sensible. If you have a treatable molecular alteration, then maybe they need to be followed up differently going forward, both in the UK and across the world. Got a quite technical question from Dr. DeCatris, who's asking about progression beyond RET inhibitors. What options are there for patients in a setting where you've progressed beyond RET?
Yeah, well, I think we're still in the process of mapping out acquired resistance pathways. So I think this general concept of having a patient with an actionable mutation progressing on targeted therapy, what are the mechanisms driving that relapse? There could be on target, as Dr. Gainor mentioned, there are gatekeeper mutations that are recognized. So I think this idea of my patient is progressing, I'm going to re-genotype them. That means tissue, liquid, ctDNA. I'm going to look at the signature, see if anything is druggable, consider a druggable option. But I think another really important part of these patients' management is looking at experimental trial therapy. So this is exactly the area where I'm on the phone to the drug development units, phase 1 units in and around my area, speaking to my colleagues there, saying, listen, I've got this problem. This is the mutation. Do you have clinical trials for my patient?
Excellent. Thank you very much. And finally, can I just ask you from my own personal curiosity, I mean, how are these duration of the adjuvant treatments selected? Why is it, 3 years for, say, osimertinib, 3 years for alectinib? 1 year for chemo IO. How is there any biological basis or rationale for which the duration of treatment is selected?
I wondered the same thing. Personally, I think it's back of the envelope. Someone's just, come out with I mean, you want to give it during the most salient period of relapse, highest risk of relapse. I would say, the AstraZeneca osimertinib adjuvant study selects 3 years. Well, most relapses happen within 3 years, and there's a concern about reimbursement if you have a treatment that's given continuously until for the rest of your life. Doesn't oncologically sit well with reimbursers and the people, the payers of healthcare, that here's a patient and we've done a curative procedure and we're now going to put them on a $5,000 a drug month for the rest of their life. Do they really need it? So I think there are lots of considerations that are both biological and financial in selecting these things.
And can I
It's
ask
interesting.
what's your view about if you then stop it just based on, say, the clinical trials arbitrary selection, where you're suppressing the driver mutation for there to be the possibility of rebound in disease?
Well, I think you can see that in Adora. So I think when you look at adjuvant osimertinib and you look at disease, the curves, and you look at the 36-month mark when the treatment stops, you'll see that the curve trajectory changes. So I think there's a degree of, and we know in the overall population, it's a positive study for overall survival. But I think there is this sense and worry, perhaps, I would say, in the community that what we're doing is we're delaying relapse, that relapse might be inevitable, and effectively we are delaying it by giving early first-line systemic treatment with osimertinib. And now even that space is moving on because in the advanced disease setting, we've got bispecific amivantamab, lazertinib, we've got chemo with osi. So maybe we're going to be looking at new adjuvant strategies in the EGFR context. But that is a very real concern that we all have as a community.
Right. Well, thank you very much for an engaging discussions, Riaz, which remains me to thank once again Justin Gainor for a fantastic presentation, our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Next week is Good Friday, so there won't be a session, and I'll see you on the week after. Thank you very much, Riaz, and have a good day.
Bye.